everyone. Thank you for having me today. Yes, my name is Lisa Nee. I'm a resident in the Department of Radiation Oncology, and today I'm going to be talking about the volumetric response of brain metastases in patients with EGFR mutant non-small cell lung cancer treated with OC alone versus with radiation. I do not have disclosures. As background, we know that 25% of patients with EGFR mutant non-small cell lung cancer present with brain metastases at diagnosis. And previously, before the era of targeted therapy, the median overall survival of patients with non-small cell lung cancer, patients with brain metastases, was low at a range of 3 to 15 months. Now, in the era of targeted therapy, median overall survival of patients with EGFR mutant non-small cell lung cancer is much longer, on the scale of 19 to 58 months. So given the extended overall survival of these patients, the question has been asked whether, the question was asked in the era of early TKIs, whether CNS-directed radiotherapy could be deferred in these patients that are presenting with brain metastases. And this was a multi-institutional retrospective analysis looking at 351 patients with EGFR mutant non-small cell lung cancer with brain mets treated with erlotinib with upfront SRS or whole brain radiation versus erlotinib alone upfront with radiation reserved for salvage therapy. And in this study, they found that on multivariable analysis, both SRS and whole brain radiation was associated with improved overall survival as compared to patients who were treated with erlotinib alone upfront. So there was this indication that in the early TKIs, there is still a benefit with upfront radiosurgery or whole brain in these patients. Then came the introduction of this third generation TKI, Osimertinib, and this agent has been demonstrated to have improved CNS penetrance as compared to earlier TKIs. So this was a phase 3 randomized trial that looked at patients that had locally advanced or metastatic EGFR mutant non-small cell lung cancer. And this found that progression-free survival was improved with OC compared to with standard TKIs like erlotinib. And this was shown in all patients and in patients with brain metastases. So this really established osimertinib as the standard of care in patients like this. So then, they also showed in this pre-planned pooled analysis of patients in the AURA trials that the CNS disease control rate with osimertinib was very high at 92%. And even early on, at 6 weeks after start of intervention, there was a control rate of 81%. So this question has now again been raised, as multiple previous speakers have mentioned, of whether we can start with upfront targeted therapy alone and defer radiotherapy in patients presenting with brain metastases. So this was a very recently published multi-institutional retrospective analysis looking at 147 patients presenting with EGFR mutant or ALK mutant non-small cell lung cancer with brain mets. And they were treated with either a CNS penetrant TKI alone, such as OC, versus the TKI with CNS-directed radiation therapy. And there was no difference in time to overall or intracranial progression between the two groups. One thing I did want to note is, of course, the limitations of a retrospective study. They did find that there were differences between the groups who were treated with radiation upfront as opposed to patients who were treated with TKIs upfront. For example, patients were more likely to be symptomatic from their brain metastases, or they were more likely to have larger brain mets. But the question that remains from this, of course, is whether we can defer radiation in all patients who are presenting with brain metastases, or whether there are patients who may benefit from upfront radiotherapy in addition to targeted therapy, or whether we can predict whether they might need early salvage therapy. So the purpose of the study I'm going to present today was to, first of all, describe the radiographic response of newly diagnosed brain mets to OC alone versus OC with CNS-directed radiotherapy, because we still don't know exactly what the volumetric response is. And then We, of course, want to know whether these volumetric parameters can be used to guide early versus delayed salvage radiotherapy. So we included 35 patients who had EGFR mutant non-small cell lung cancer with brain metastases and included 186 newly diagnosed brain mets between 2014 to 2020. We looked at the outcomes of local control, distant brain failure, overall survival, and we also focused on the volumetric response of brain metastases over time. And just a little more detail on how that was done. It was done via manual segmentation using T1 weighted post-contrast MRI. And then we included brain mets with initial tumor volume of at least 0.1 cc's in the volumetric analysis, and that was 106 brain metastases. Just showing that the characteristics of our patients are on par with other studies that have looked at patients with brain metastases with EGFR mutant non-small cell lung cancer. Overall, we had a median clinical follow-up of 29 months, radiologic follow-up of 26 months. We found that overall patients had excellent local control of 94% at 1 year, 86% at 2 years. Freedom from distant brain failure was lower at 80% at 1 year and then 54% at 2 years. And then overall survival was 89% at 1 year, and at 2 years it was 66%. We found, similarly to the published retrospective analysis, that there was no difference in overall survival in patients who were treated with OC alone upfront versus OC with CNS-directed radiotherapy. We also found that there was no difference in local control or freedom from distant brain failure. I've just shown the local control Kaplan-Meier curve on the left. What we did find is that the early volumetric response of brain mets did differ between intervention groups. So by early volumetric response, I mean response at the first MRI that patients got after starting their intervention, being OC or OC plus radiation. And that MRI was taken at a median of 2 months with a range between 1 to 4 months. The median radiographic volumetric reduction was significantly higher for patients treated with OC and CNS-directed radiotherapy with a volume reduction of 80% of baseline volume versus OC alone with a volume reduction of 41% from baseline. And then on the per lesion analysis, we found that early radiographic volumetric response was significantly associated with improved local control. So in tumors that have had more than an 80% volume decrease from baseline at early follow-up, their 3-year local control was 98% versus 72% for patients who had less significant volumetric response. And I've just shown an example of the robust response that you can have from brain metastases treated with OC and SRS upfront. So this top left is baseline imaging at time of intervention, and then this second bottom right image is from 3 months after OC and SRS. So in summary, the combination of OC and CNS-directed radiotherapy is significantly associated with greater early volumetric response in brain mets compared to patients treated with OC alone. Brain mets with significant volumetric response at early follow-up remain well controlled in the long term, indicating that perhaps deferring CNS radiation is the right call in these patients. And then patients whose brain mets demonstrate limited initial volumetric response may benefit from targeted radiotherapy to provide long-term control. I want to thank you to my mentor, Steve Ronstein, and also the rest of the team. And thank everyone for their attention. I'm happy to discuss offline, and thank you for having me.